Orchidia Pharmaceutical Industries proudly announces the IOPROS can now be stored on the shelf at temperature not exceeding 30 Celsius for the proposed shelf life 2 years. IOPROS is now stable with no significant physical or chemical changes at 30 Celsius for the proposed shelf life 2 years. IOPROS shows the best tolerability profile across multiple dose prostaglandins analogs. Another product for your glaucoma patients is Travenorm. Travenorm helps more patients achieve desired IOP reductions. Thank you for your time.
Bismillah ar-Rahman ar-Rahim. We start our 7th episode on glaucomatology, on angle closure glaucoma. This episode is honored by having two of the best glaucoma experts in the country, Professor Dr. Ahmed Mustafa and Professor Dr. Yasmin Said, both from Cairo University. We are pleased to have them. Dr. Ahmed Mustafa is well known for his glaucoma management, glaucoma expertise, interest in teaching, interest in training of the young ophthalmologists. He has his society which is promoting education for all ophthalmologists, actually, not only the young ones. Dr. Yasmin, again, is not to be complimented. She is already well known for her extensive activity, scientific activity. And by the way, Dr. Yasmin, she was the one who brought the name of glaucomatology to this series in the beginning. We are happy to have both of them, and we promise ourselves a very rich session by these two experts. We leave the microphone to them to start the session now.
Thank you, Dr. Ahmed, for this very nice introduction. So I'll start sharing my screen, and I'll start with an overview of angle closure glaucoma. So the story starts at this point where you find in your clinic that one of your patients has a shallow anterior chamber. As you can see here, as evidenced by the Van Herrick sign, the peripheral anterior chamber is very shallow. This patient is usually a hyperope, so if you check their refraction, it's usually over +2.5, but sometimes they're not hyperopes, and sometimes they have small eyes that is masqueraded by nuclear sclerosis that had led to some myopia, so it hides the hyperopia. But these eyes necessitate performing a gonioscopy to be able to manage them properly from this step on. So what is primary angle closure? Primary angle closure can be either appositional, which means that the iris, the peripheral iris, is close to the angle, or synechial, which means that peripheral anterior synechiae has started to build up in the angle. The mechanism in more than 75% of cases is a pupillary block. And the reason for that is that most of these eyes are small. So with the age-related increase in lens thickness, as you know, we all develop more and more layering of lens fibers as we grow older. So at some point, usually in the 40s or 50s, the apposition between the pupillary edge and the anterior capsule of the lens becomes difficult for the aqueous, makes a valvular mechanism that makes it difficult for the aqueous to move from the posterior chamber into the anterior chamber. So what happens is the pressure gradient between the posterior chamber and the anterior chamber starts to build up from a normal 0.25 millimeter mercury and up to 10 millimeter mercury or more. And this translates into an elevation of the iris. So the iris will start to rise and develop the Bombay. As a consequence to that, three things will start to happen. The aqueous will start suffering in reaching the angle, so that with this narrowing of the angle, it will make it more difficult for the aqueous to drain. So the pressure may start to rise. Second, the iris, the peripheral iris, will cause friction with the trabeculum. So two things will happen. The trabeculum will become dysfunctional over time, and this is a very important point that will guide our management later, and is a justification for early intervention of many cases, that with the long-standing friction with the trabeculum, these eyes turn into sort of open-angle glaucomas with trabecular dysfunction. And finally, the third thing is the buildup of peripheral anterior synechiae over time, with the constant friction. So this is the pupillary block mechanism, which is responsible for most cases. There are other less well understood mechanisms. The other second most common is the plateau iris configuration, which we know is caused by a ciliary body rotation, a patient that has anatomically forward rotation of the ciliary body that mechanically pushes the peripheral iris. So it causes an occlusion, not by pupillary block because of the apposition, but because of the position of the ciliary body that's rotated forwards. More often than not, these eyes are also associated with a pupillary block for reasons that we don't understand yet. Other less well understood mechanisms include the location of the iris insertion, which is again anatomically predetermined. Some patients have a high iris curvature, and some patients are born with an iris that is more closely appearing from the angle than others. And the iris volume, there have been some studies that looked at the increase in the iris volume in the mid-dilated position, and they found that patients who are at risk of acute angle closure attacks are more likely to imbibe more fluid from the aqueous in the mid-dilated position, and so they're more likely to have occlusion of the angle. So the iris volume is another issue that we don't fully understand, but it is a culprit in this problem. But the main culprit in all cases is the lens. Angle closure glaucoma never happens in a phakic or pseudophakic eyes from the start. So if it hasn't been for the age-related increase in lens thickness, no patients would develop angle closure or angle closure glaucoma. So the newer or relatively new classification of angle closure is the PACS, which stands for primary angle closure suspect, previously called occludable angles, and PAC, which is primary angle closure, and primary angle closure glaucoma. So what's PACS? PACS is when you have at least 180 degrees, so half the angle is occluded by iridotrabecular contact. And iridotrabecular contact means that the iris is in touch with at least the posterior pigmented trabecular meshwork, if not the anterior structures as well. At this point, there are no peripheral anterior synecdoche resulting from the friction, and the IP is still normal because, yes, the aqueous is suffering to reach the angle, but it hasn't reached the point where the pressure started to rise. It's very important in these cases to make sure that you're examining the angle in the primary gaze and without compression, because as you can see here, if you compress a little bit with indentation gonioscopy, or if you allow the patient to look towards the lens, you can inadvertently open the angle and overestimate its width. So you need to adjust in the primary position and without compression. Now, with time, with the more and more the pressure gradient increases and the iris bombay increases and the aqueous suffers more in reaching the angle, the trabeculum becomes more dysfunctional, more PAS will develop, so the pressure starts to rise. At this point, the patient is classified as a primary angle closure. So again, primary angle closure is an apposition in addition to either an elevated IOP or PAS or both. Again, with time, with a high pressure, just like ocular hypertension, with primary open angle glaucoma, some patients develop glaucoma and others don't. So with time, a subset of these patients will develop glaucomatous optic neuropathy. At this point, they're labeled as primary angle closure glaucoma. This can be associated with visual field defects or maybe still pre-perimetric. So but if you have a high pressure with iridotrabecular contact over 180 degrees or more and glaucomatous optic neuropathy, then you have a diagnosis of primary angle closure glaucoma. One last subset is the acute angle closure crisis, which was previously called acute congestive glaucoma, but it turned out to be a misnomer, this name. First of all, because not all cases develop glaucoma. If you save the eye timely and you lower the pressure, the glaucomatous optic neuropathy may never develop, so they may not develop glaucoma, just an angle closure and an acute rise in pressure. And the second misnomer was congestive, because these cases, the main pathogenesis is not congestion, as we will see. So a more appropriate and accurate name would be acute angle closure crisis or acute angle closure attack. Now the management, and there are many controversies in angle closure. I'll point out the controversies when we reach each of them in turn. So how would you deal with a patient with primary angle closure, a primary angle closure suspect? Primary angle closure suspect, previously called occludable angles. As a reminder, so these are patients with just narrow angles over at least 2 quadrants, no PAS. The IP is still very normal, 10 or 12, and they don't have glaucomatous optic neuropathy. Well, unfortunately, there isn't very strong evidence to point to the benefit of whether you need to intervene for these patients or not, or there is some evidence, but it's quite controversial. So a study from India looked at these prospectively, those primary PACS patients, and found that 25% of those will develop an increase in IOP or peripheral anti-synecdoche over the 5 years of the study period. I'm not aware of any longer term studies. It's very difficult to observe a very large subset of patients with PACS and be able to tell how they will behave over the following decades, because this is the design you need to know how it behaves over the long term. They advised on doing PI for these patients to reverse this from the start. More recent evidence from the ZAP trial from China showed there isn't much benefit in doing PACS, and they advised that it is time-consuming and money-consuming. But again, you can't extrapolate the results from China to Caucasian or Middle Eastern eyes. We need to have our own studies. So, to cut a long story short, there are no clinical trials that support strongly the benefit of doing PI for patients with these occludable angles, narrow angles. Yet, PI is a relatively safe procedure. You can perform it in eyes with iridotrabecular contact, with a normal IP, without PAS. And as more and more evidence is appearing, we're attempting more to individualize the treatment for these patients. So I used to do PI 5 years ago, maybe to all primary angle closure suspects. Now I individualize it more. So it's controversial still. I would definitely do PI for patients that are using medications that may cause pupillary block. These are usually cold medications, antihistaminics, anticholinergic medications. Any medications that dilate the pupil, and the patient will need to go on those for a long time, may risk precipitating an attack of acute angle closure. So these patients are indicated for PI. Any patient giving symptoms suggestive of previous acute or subacute attacks are indicated for peripheral iridotomy. Patients who need frequent dilated fundus examinations, like diabetics, will be safer having a PI. Patients, which applies to a lot of patients in our community, patients whose health or compliance with residents would not allow them to have regular checks for their angles and IP, or they may be reluctant or delayed in reaching medical care if they develop an acute elevation in IOP. So elderly ladies that live far, all these patients I strongly consider and advise doing PI for even before the pressure starts to rise. Now, for patients where you decide not to do PI, PACS patients where you decide not to do PI, you still need to follow them up, of course, because you can expect that in a subset of these, the pressure will start to rise. So you follow them up for IP elevation, progressive zipping up of the angle, or synechial angle closure. If they start developing these progressively, you can start considering to do a PI for them. And if you don't do a PI, again, you need to warn them for of the risks of acute angle closure attack and the symptoms of acute angle closure or subacute angle closure attacks, and warn them from the medications that can precipitate an attack or narrow the angle further, like over-the-counter decongestants and anticholinergic medications. Mind you, all the drug pamphlets that mention that it is contraindicated, that this drug is contraindicated in glaucoma patients, they're referring to angle closure, and not just glaucoma, but angle closure in general, the whole broad classification of angle closure, starting by PACS, PAC, and primary angle closure glaucoma, except of course steroids, which can cause open angle glaucoma. All other medications that have a warning not to be used in glaucoma patients, they mean angle closure patients, regardless of whether or not they have glaucoma. Now, if you reach the second stage or the third stage, primary angle closure or primary angle closure glaucoma, which means that there has been an increase in IP because of the compromise of the aqueous outflow, either because of the apposition with the iris bombae or because of the buildup of peripheral anterior synecdoche, or as we mentioned earlier, because of the trabecular damage from the constant friction. So the pressure may start to rise, and in this case, you need to do something about it. You can't just put them on medications like an open-angle glaucoma. The options here are either to do a PI or phacoemulsification. Again, this is a controversial bit. There is contradictory evidence to support each of those, and again, you may need to individualize your decision to every patient. It's not wrong to do a PI only, and it's not wrong to do a phaco only, especially if the patient has an early cataract. Now, if you decide to do a PI and the pressure remains high, so this is a patient, again, with a narrow angle, a high pressure, whether or not they have glaucoma, and you decided to do a PI rather than a phaco, why would the pressure remain high? Normally, if you reverse the pressure gradient by doing an opening in the peripheral iris, and the iris will flatten, so the pressure should normally drop. But of course, there are reasons why the pressure would not drop. First of all, it could be that the trabecular damage from the time the patient earlier had the friction led to sort of an open angle element where the trabeculum itself is not filtering properly. And this is a justification, as I said earlier, to go ahead with PI earlier, maybe in the primary angle closure suspect phase, to avoid this trabecular damage over the long term. The second reason could be the buildup of synechia. So if you have a 180 degree or more synechia, it's unlikely that PI would be effective. The PI may be too small or may become occluded, which is very rare. There may be other non-pupillary block mechanisms for the angle closure, like plateau iris configuration or syndrome, and the patient may accidentally have both primary angle closure glaucoma and primary open angle glaucoma. Having a primary angle closure glaucoma does not preclude or protect this patient against having other types of glaucoma as well. That would be a very unlucky patient, but it is possible to have different mechanisms of glaucoma. So it could be that primary angle closure glaucoma was not the main reason for the high pressure. So what do we do if the pressure remains high, even though we did a PI? Some would advocate iridoplasty. I'm not an avid supporter. I tried iridoplasty a few times, and I wasn't very happy either with the result or the procedure itself. It's a very painful procedure. You can start your patient on drops, just like open angle glaucoma, but actually, if there is room to do cataract surgery, especially if this patient has an early cataract, it would be more useful to reverse the whole process from the start and open up the angle and remove the main culprit in this whole problem, which is the lens. So phacoemulsification is very justifiable in the setting of patients that still have a high IOP despite peripheral iridotomy. So why not do trabeculectomy for these patients? Of course, we strongly advise against doing TRABs alone in angle closure cases in general, all of them. TRABs have been shown to have a high risk of failure in angle closure. They scar more. The post-operative AC shallowing that already happens with trabeculectomy. All trabeculectomy cases have a shallower AC, and if the AC is already shallow in angle closure, this will make it too shallow. And most importantly, the risk of malignant glaucoma, albeit rare, but it is there, and it can be detrimental to the patient. And finally, patients do develop some galloping of their cataracts or new cataracts after a trabeculectomy. So if the cataract removal, if the lens removal is successful, then why not start with removing the lens from the start? I will discuss more the role of phacoemulsification and angle closure after Dr. Ahmed Mustafa's talk. Thank you.
So is the screen clear?
Yes, we can see it, Dr.
Yes. Yes. So first of all, I would like to thank my dear friend, Dr. Ahmed Khalil, the president of the Egyptian Society for the Glaucomas, for the kind invitation, for the nice introduction, and for the great efforts in making such virtual, highly educative sessions. And also, it's a great pleasure for me to share this session with my dear colleague, Dr. Yasmin. I always feel very happy, and I'm quite sure that I come out of this session with a new piece of information after sharing a session with my colleague, Dr. Yasmin. So that thank you very much for that. Now, I will just comment on a few points related to gonioscopy in patients with angle closure glaucoma. You know that during the diagnosis, we depend on what's known as indirect gonioscopy. And the most common lens is, of course, the 3-mirror lens, which is still the gold standard lens for the evaluation, because you can fix the globe at the time of examination, especially for the beginners. The 3-mirror has a wide base, 12 millimeter. That's why we need a coupling fluid to be used to fill that concavity of the lens. And then the other lenses are the indirect lenses. Of the indirect lenses are the 4-mirror lens, which I think they are very big friends of the glaucoma surgeons, because we use them very frequently. They have the big advantage of having narrow base, so that we don't use a coupling medium, and we use them for indentation. And the two famous lenses are the Postner and Sostman, and this is an example of the Sostman lens, and this one as well. There is no handle, and this is the lens that's most commonly used. You might be trained to use the Postner as well, but it needs a kind of training to hold the lens from its handle. Now, generally speaking, when you look at the angle structure, again, to proceed with management of any type of glaucoma, whether it's open or angle closure glaucoma, we need to examine the angle. We cannot start treatment before that. And then if you look at the left side, this is a beautifully open angle. But when you look at the right side, the angle structures are not seen at all. So that from that point of view, now we are dealing with a patient where the angle is probably closed. And then these are the basic structures of the open angle we will not go through. But when you look at the iris, you can see a picture like that, because we need to comment on the configuration of the iris as well and the level of the iris insertion. But we can have this picture, and we really don't know whether the angle is still open behind that iris or not, because still the angle could be functioning and open, and the iris is still having that configuration. That's why when you apply the lens, and then you cannot see the angle structure, because that you see the iris is a bit convex or high, what you are going to do is just you need to slide the mirror towards the angle, or you ask the patient to look towards the mirror, so that in this way, if this is the iris that's a bit convex, you need to overcome this iris, and then you need to have a look on the angle, either to move the lens towards the angle or to ask the patient to look towards the mirror. Any of them will help you in identification of the angle structure. That's called over the hill, because this iris is considered is like a hill. And then when we have a patient with an angle closure glaucoma, we cannot diagnose the condition properly without indentation gonioscopy. So that when do we do an indentation gonioscopy? Generally speaking, after you perform Van Herrick, as Yasmin have said, and then you find that the AC is shallow, and then you will do a gonioscopy including the indentation. If the scleral spur is not visible, and then you need to, or the iris is convex, you need to indent the cornea. The idea of that you need to differentiate between appositional and synechial angle closure, like what's seen in the here, because actually you need a small area of contact, gentle push, and the patient should be in the primary position, as Jasmine have said. What happens is that when you indent the cornea, the aqueous will move to the periphery between the iris and the cornea and will try to open this space. Now, if the iris is adherent by synechia, you will not be able to see the angle. On the other hand, if it is just the iris is coming close to the cornea, now once you indent the cornea, you will be able to see the angle structures like here, so that when you look here, you apply gentle pressure by, this is a 4-mirror lens, and 4-mirror because you can see the 4 quadrants of the angle without having to rotate. You can tilt the lens, but you don't have to rotate this lens. Now, if you indent the cornea and you still see that picture, so that I'm not able to see the angle. Now, in this is one scenario, and the other scenario is here, when you indent the cornea and you get some striae, you have to try to avoid this striae by gentle pressure on the center of the cornea. And then now you are able to see the trabecular meshwork and probably parts of the scleral spur. They are two different conditions, because if the patient is having that appositional angle closure and is having features of glaucoma, especially like elevation of the pressure, or is just in the, you know, that you have diagnosed the patient as glaucoma, now those patients can benefit a lot from PIs. But patients with synechial angle closure most probably will not benefit from the PI. So before performing the procedure, you need to know in advance whether the patient is going to benefit or not through the indentation gonioscopy. Now, in this case, when I did gonioscopy, then I found that picture. This is just part of the trabecular meshwork is seen. This is not an open angle, because for the angle to be open, you need to see nicely the posterior trabeculum, and you need to see the scleral spur. So this is still a closed angle if you see the anterior trabeculum. Now, the next step I'm going to do again, indentation. Look, when I'm going to indent again, the iris will bow to the back, and the angle is still, the features are not so much improving. So with that, you are not so confident whether this angle will open or not. And this is the inferior angle, of course, so that, or the other way, or the other hand, you will see the angle will nicely open. So you need to differentiate. Again, this angle is a synechial closure, and this is an appositional closure angle. Other point, when you do gonioscopy, you still can see the occlusion of the pupil by the lens when you indent slightly, so that you can confirm that this lens is inducing a kind of pupillary block at the time of indentation gonioscopy. Now, when the angle features are not seen, you can help yourself by what's known as the corneal wedge. And the corneal wedge depends on the principle is that if you get a very thin beam of light, and then try to do this on the inferior angle, it is the widest angle. And then that beam of light will be reflected first on the back of the cornea. It will be very clear line. And then we have another outer line on the outer surface of the cornea, which is a fuzzy one. And both of those two lines, they meet at the Schwalbe line. Then I need to determine the relation between the Schwalbe line and the iris, because if there is a good distance, it means there is a good angle space for the angle. If they are in contact, it means that probably the angle is shallow. And then we will, again, this is the point of meeting, this is the iris, and then we need to think of the distance. Is it enough angle or not? And this is just in real life, when this is the back of the cornea, and again, this is the anterior surface of the cornea, a fuzzy line, and again, they will meet somewhere here, and then this is the end of the iris, and then this is the distance of the angle, because some angles are so much hypopigmented to the extent that you cannot say, is this a trabecular meshwork or not? So that by doing that technique, you can say, yes, this is a hypopigmented angle, most probably. Again, this is a different scenario where you see the posterior line on the back of the cornea and the anterior line, and they meet here, and then there is no distance. So the iris is just at the Schwalbe line, and this is an occluded angle. Another point when you examine the angle of patients with the angle closure glaucoma is to find peripheral angiosynechiae, as Dr. Yasmin have said, and those are broad, and usually they are fixed, and they do not move enough with the movement of the iris. Now, if your patient have got an attack of angle closure glaucoma and you did PI, and then the patient got another attack, think of the plateau iris, and with that you can find the peripheral elevation of the iris by the anteriorly rotated ciliary process. Is called the sine wave, so that you will diagnose that on gonioscopy, and you will confirm definitely through an anterior segment UBM. Other findings, now this patient underwent trap, and then you can check the patency of the trap, and you can see the patient is having very broad peripheral anterior synechiae. Now, you know why this patient underwent surgery. The angle is completely occluded. Some features you can get with gonioscopy. Again, when you look at this eye, and the patient is having some iris pathology, And then when you move along the angle, you'll find the angle is completely occluded by broad peripheral anterior synechiae, and then a normal angle starts to appear here, and then you can delineate the areas of peripheral anterior synechiae. Again, a patient underwent angle surgery, and then on evaluation, a lot of peripheral anterior synechiae that was done intraoperatively. So a lot of details you can get through the gonioscopy, whether it is the direct or indirect. Now you need to have some information on the angle grading system, and Dr. Yasmin just have touched upon the Van Herk method, in which we use a very thin beam of light thrown on the temporal cornea, and then compare the thickness of the cornea to the depth of the anterior chamber. Generally speaking, if this space is almost half of the cornea or more, this means this is an open angle. Otherwise, we are dealing with a narrow angle, but it is not conclusive. Again, these are the details, so that all the angles usually it has to be more than half to feel relaxed about being an open. Otherwise, there is a suspicious about the angle closure. And the simplest system we are using is the Schaefer and modified Schaefer, which they are depending on some numbers, whether they are Roman or just the numericals, and each number is reflected on 0. Actually, no angle structures. This is already closed, and then if it is 1, we see only Schwalb's line. It's a closed. 2, if we see trabecular meshwork, closure possible. So just remember, if you just see the trabecular meshwork and this angle is still a closed angle, you need to see the scleral spur to make sure that this is an open angle. And of course, with the ciliary body, this is a widely open angle. The most comprehensive system is the SPACE system. I don't want to go through the details of that system. It is very helpful for the evaluation of different types of glaucomas. It depends on the level of iris insertion, the angle itself, and the shape of the peripheral iris. It's one of the most comprehensive systems. So again, if you are going to do gonioscopy, then you need to confirm if you find the AC is shallow with the Van Herk, or the patient is already known as glaucomatous. Yes, Van Herk can give you a clue to the diagnosis, but it is not conclusive at all, because you still can do a Van Herk and you have the impression the angle is open, and then on actual assessment of the angle, you will find it close. And so, so again, you need to do gonioscopy, and not to say that I would just do Van Herk. And then you can use the 3 mirror at the first, and then you can focus on the inferior angle, and then you need a 4 mirror to do proper indentation gonioscopy to make sure is it a synechial or a positional closure, because the management is different. And then I want to thank my dear colleague, Dr. Rana Hussein, because she helped me a lot during the preparation of such a presentation about the angle. And with that, I thank you very much.
Thank you very much, dear Ahmed, for this very enriching talk. And before going actually into the rich discussion our scientific coordinator, Professor Nader Bayoumi, is preparing for you, I would like to mention for all our attendees who have attended the previous 5 or 6 episodes that you probably received the email for the CME examination. The CME examination is already posted online since 10 a.m. this morning, and it will remain there for you to answer the simple questions depending on the previous sessions till tomorrow, inshallah, tomorrow, Saturday, 10 a.m. So they are available for 24 hours, which will end, inshallah, next morning at 10 a.m. Thank you very much, dear honorable speakers. And I leave you to Professor Nader. And I see also that we have Professor Adel Abdel Shafi if he has any questions later on. Dr. Nader, بيتفضل.
Sure. Dr. Yasmin, Dr. Ahmed, thank you very, very much for this excellent presentation and talks about angle closure. I would just like to raise just a few issues, and I would like to seek your expert opinion in just a few issues. Now, let's start with asking about provocative tests. You know, as Dr. Yasmin mentioned, that the issue of performing a PI for an angle closure suspect is a rather controversial issue. Dr. Yasmin mentioned that you find the patient with a shallow anterior chamber, hyperope. So, and if you look at the angle, you find it a positionally narrow or a positionally closed. So, are there any provocative tests that you rely on in first answering the question to do a PI or not, or maybe to take the treatment to another step further? So, we would like to hear your opinion about that.
Yes, Yasmin, please.
Provocative tests have been there for decades, and despite that, there isn't strong evidence to support their usefulness. New things may come up, but for the time being, I don't rely on them up to this point in time. But it could be that with more advances or more different provocative tests may come up that may change our minds about this.
Would you allow me to interrupt you here and ask, do you rely on any part of the history of the patient? Let's say, for example, do you ask about the patient about their sleeping habits, if they do sleep prone, for example? This is an already made dark room prone test, or you don't rely on that in the history part?
No, to be honest, no. I never asked them. What I rely on, if they give any symptoms of previous subacute attacks, I take that into consideration. But whether they sleep in a dark room or not,
sleeping prone. They sleep on their face, I mean.
As a sort of provocative test, or because these patients particularly like to sleep?
No, in their habits. Sometimes many patients, in their sleeping habits, they sleep prone.
This is a very interesting point you're raising, Nader, but I'm not sure if we can look into that. But I tend to follow what the available evidence. But we can definitely consider asking about that, or doing a study that can look whether these patients are more prone or not. The problem in designing a study to see which patients are more likely to develop glaucoma or an acute attack is that acute attacks are already not very common. So we would say they're in the range of 1 in 20, 5%. So that's 5%. So in order to compare two groups, it would be very difficult because it's already a rare occurrence, albeit very serious if it happens. So for now, it's difficult to design a study, but we can consider thinking which patients are more prone in terms of their sleeping habits. Yes, for sure.
Ahmed, do you rely on provocative tests, sir?
Nader, the development of glaucoma is an interaction between some anatomical and some physiological factors. So it is not just an anatomical abnormality. That's why patients with the shallow anterior chambers tend to have the pupils dilated for fundus examination as a routine work in some of the clinics, because you really don't know which patient will get an attack. And as Yasmin have stated, generally it is like 10 to 5%. But personally, I do not depend on any provocative test for the angle closure glaucoma to initiate an attack, or to just to measure the pressure after dilating the pupil. No, I don't do that.
Sure. So it's the gonioscopy and your clinical sense with your patient that governs the issue. Okay.
It is. The point is that it is not easy when you have a patient who is a PAX. I saw that, and the patient is having nothing, and then you try to convince this patient to have PI. It's not an easy job, I think, Yasmin, to do that. So that generally the recommendations, it is just to observe those patients, and unless you have like a problem in the other eye that you find, like Yasmin would have said, some kind of pigment dispersion, some pigments on the lens that could guide you to a previous attack, so that you need something in your hand to proceed further for management.
Some solid evidence.
Yes, a kind of solid evidence, because they are usually having quiet eyes. And you know that I personally don't like to operate on an eye that's really so quiet.
Excellent. I'll pick up that part that you said, sir, and I'll build up on two words that I've mentioned in the presentation, that the PI being a relatively easy procedure, and to perform a phaco and to solve the problem all through. So I would like to hear your opinions about the PI in our brown eye reads. I mean, this webinar is being held in Egypt. I know we may have international speakers, but this webinar is being held in Egypt. the parameters that we all read in books about PIs, the laser settings. I mean the settings of the laser machine in simple words. Yeah.
Yes. Yes.
Are they do they apply for these dark brown iris that we do face in the Orient, generally speaking? And are the or let's say, is the safety and guarantee of the procedure exactly in the Orient here in the iris that we see exactly the same as that described in books on Western iris mainly? Do you find the difference? That's the first question. And let's say after it directly, if phaco would be recommended, you do have recommendations for phaco in such shallow ACs. So you would like to share us your experience about these two issues: PI in oriental eyes and phaco in shallow ACs.
Look, Nadir, yes, the information is very clear. So that when I have a patient, well, for example, with a lightly colored iris, and then the iris will open from the first shot, and then I cannot express my great happiness to that. On the opposite,
Laser
when I have
power,
a
sir, I'm sorry to interrupt you. What laser power do you start with? It's very
I
critical.
use I use 6 millijoule. I start with 6 millijoule. You know, it depends on the machine. Definitely, when the machine is a
Sure.
bit new and generating, that full power laser is different. But generally,
Sure.
I start with 6 millijoule, and then if it opens, that I feel so happy because I know
Sure.
that the patient who did not receive a lot of laser treatment definitely will recover so fast in the postoperative period, so rapidly. On the other hand, you need to concentrate on the thickness of the iris because the dark iris, and there might be a role for assessment even with the UBM. I
Yasmin
think
has raised the issue of the iris volume.
yes, yes. I think I have regretted that I did not inform some of the patients that we might do the laser on 2 sessions, because you keep digging into the iris and then you start another location and then you have to stop when there are clouds every there,
Never
and then
seem
you
to reach
feel
the base.
when you feel so embarrassed that you have to tell your patient, please, we need to continue the laser on a second session. And definitely I feel so worried on my patient to develop any kind of glaucoma at that time when I leave him with a huge reaction in the anterior chamber and PI that is not completed. So I think it seems like a wise decision when you evaluate the iris and then you think in the future, if it is possible to go with phaco instead of digging that very brown iris. I think that's a good point to be investigated. I think so.
There remains any specific, let's say, telegram-like message for phaco in shallow ACs? That's, I know it's a very big
I
issue,
will
but
talk. I
let's
will talk.
say
I will talk
bullets.
about that, Nader. I will talk about that in my
Me
next
too.
talk.
Yeah, that's my
Sure.
next
Yes,
talk
we
as
will
well.
cover such
Okay.
That's the
difficulties.
next
Yes,
So
session.
yes. Yeah, it's not
I'll
a
finish.
piece of cake.
I'll finish this question and answer by a question from the floor. Is there any relation between GA and spinal anesthesia and angle closure glaucoma? We have this question from the audience. General anesthesia and spinal anesthesia in relation to angle closure glaucoma?
You mean a patient subjected to general
Yes,
anesthesia and
that's
then
the question. Yes.
went through the phases of pupillary? I really don't know.
No specific evidence
But you
based
know that
on general.
we did not receive, that in Al Qasr Al Aini we receive, calls from all departments for patients
Sure.
suffering after in all departments, so that we can receive, for example, some information about patients who just kept prone for quite a long time on their eyes, so that. But for a patient who developed glaucoma after GE, I really I don't have any information, but we do not have that in the clinical grounds. So I think
We have another question. A patient around the 40s with a patent laser peripheral iridotomy, and the intraocular pressure is still high around the 30s, and the plateau iris is suspected and the UBM is not available. So is there any way out of this situation? Laser PI patent, pressure in the 30s, patient is around 40s, a plateau iris is suspected, but there's no UBM machine available. So is there anything out of that situation? You go for a phacoemulsification, for example, do you do with a gonioscopy or a trab, although
yes,
we just
yes.
mentioned
Meanwhile,
trabs are not recommended.
yes.
Yes,
Yeah,
Meanwhile,
we'll
do you
discuss
think?
that in a moment. So plateau iris again is a very rare disease we know little about. We're not really sure if phaco works alone. There is little evidence to support that phaco alone works in these cases, unless there's a pupillary block mechanism that we're not aware of, and that's associated, just like I said, they're usually associated together. So you don't know which of these cases is definitely less likely to respond to phaco alone than primary angle closure glaucoma, non-plateau iris configuration. So I'll probably, if depending on the glaucomatous optic neuropathy, how advanced it is, for these cases, I would either go for a phaco if they're not advanced, or phaco chab if they're advanced.
Okay, sure. Now, we'll stop now for these question and answers. Now I'm so eager to hear the rest of the information about phaco and the plateau iris. So please take the lead. Thank you.
So now phaco in primary angle closure and primary angle closure glaucoma. As was mentioned earlier, we all developed anterior chamber shallowing as we grow older because of the age-related increase in lens thickness. But patients predisposed to have primary angle closure glaucoma already started out with a shallower than normal AC. Not just that, but also many of them are found to have a significantly thicker lens. So the axial lens thickness of these patients, axial lens thickness, is greater than the average normal subjects. And mind you, this is whether the lens is opaque or clear is irrelevant. We're just talking about the thickness. So it could be that the lens is very thick but still clear, and it could be that it's cataractous but not that thick. So this is the same patient that we were examining the gonio for a while ago, and now the angle opens up with indentation. And so what lens extraction does, and you'll see it in this patient, is that it deepens the anterior chamber and opens up the angle. Once you remove this thick lens, you widen the angle, deepen the anterior chamber, and as you can see here, now this is his angle after the phaco without indentation. It completely opened up. It also decreases the diurnal IOP fluctuations that we see with angle closure cases because of the subacute or minimally acute attacks they develop over the day. And phaco also improves the facility of outflow in these cases. In a report by the American Academy of Ophthalmology in 2015, they looked at the different studies, the level 2 and 3 evidence studies, which is very high level of evidence of studies that looked at the effect of phacoemulsification in primary angle closure glaucoma. And out of 500 eyes collectively in these 12 studies, the pressure dropped after an average follow-up of 15 months, from 20 preoperatively to 14, and that's from 2 medications on average preoperatively to 0.8 medications postoperatively. More importantly, more than 60% of these patients with primary angle closure glaucoma were off medications just by having phaco. So phacoemulsification can put more than 60% of primary angle closure glaucoma patients off medications up to an average of 15 months. Now, the effect is even more pronounced in acute angle closure cases. First of all, because you're starting out from a very high pressure. And as you can see here, collectively from these 4 studies, the pressure drops from 50 to 14. We're talking a 34% drop in IOP because you're starting out from a very high pressure, and because these patients have very shallow anterior chambers with very thick lenses that respond remarkably well to lens removal. So phaco is even more effective in acute angle closure glaucoma. So what are the indications for phaco? The indications, to cut a long story short, are the same indications of when you would decide to do a trab for an open angle glaucoma. So you have an angle closure case that has already done a PI, and or that hasn't, and you're considering whether to do a PI or a phaco. But then when would you consider to do a phaco? If the pressure is uncontrolled on maximum tolerated therapy, if the patient is non-compliant to his medications, if there's deterioration despite medications, if the patient prefers to have a surgery. The same indication is where you would say, okay, I'll go ahead and do a trab in this open angle glaucoma patient. In the setting of angle closure, you go ahead and do a phaco. But there's another indication that makes it more likely to do phaco in these cases, and that's the presence of a visually significant cataract. So you have a patient with borderline control of IP or even good control on 1 or 2 medications, you can put them off their medications. If they have a visual significant cataract, then go ahead and remove it. So we have a much lower threshold in removing the cataracts for angle closure patients than we do for the regular population with open angles. The surgical technique, as Dr. Nader, you were raising this point, is very different than the straightforward phaco. This is not a case for a junior surgeon to perform. Usually the pupil, especially if the patient with 2 previous acute or subacute attacks, is narrow, so you often need the help of iris hooks. You need to go in beyond the edge of the iris. Let me just, show this again. The entry point should be beyond the edge of the pupil, otherwise the pupil will keep on coming out of the incision. And you need a soft shell technique where you use dispersive viscoelastic to coat the endothelium and cohesive viscoelastic to strongly form the anterior chamber and compress the high volted anterior capsule of the thickened lens. If the AC is very shallow, you can use the help of vitreous tap. We rarely need that, but in very advanced cases, you may use the cutter, a 23 gauge cutter or a needle to aspirate some vitreous to deepen the AC. Once you've removed most of the lens matter, it becomes more of a straightforward case, but mind you, the capsule is stretched with this thickened iris, so thickened lens, so it may be redundant during the IA phase and may be aspirated into your aspiration port, so be mindful of that. You can combine that with gonioscopy or viscogonioscopy. I often do injections blindly without the guidance of gonio lens, so I just inject viscoelastic at the very end of the procedure into the angle and wash it so it would lyse some of the synechia and widen the angle. There are some observations with doing phaco in angle closure cases that have been mentioned in some studies. First of all, the PAS extent has been noted to be reduced after surgery, even if you don't attempt to do goniosynechiolysis, interestingly. And the reason for that is that the mere entrance and exit of fluids and viscoelastic, they do lyse the peripheral anterior synechia without you having to attempt to lyse them with visco or with an iris repositor. Another observation is that if you have a residual open angle after the operation, you cannot still guarantee that the pressure will go down. And that's for all the reasons we mentioned before. The trabeculum could be dysfunctional. It could be that the patient has another mechanism for their glaucoma. So having an open angle is not great news because it doesn't always associate with the pressure lowering. So it would be useful to know which patients would respond more to phaco. So for these patients, you can go ahead and do phaco alone. And if they have poor prognostic factors that would make them less likely to respond to phaco alone, you can combine that with other procedures like a trab or an angle surgery. So still, I mean, to cut a long story short, there isn't strong evidence, but I will present some of the available evidence for now. Most studies found that the higher preoperative IP, the more the IP dropped with the phaco, and that's because the more aggressive or the narrower the angle and the shallower the AC, the bigger the lens, the more it will respond to lens removal. So the higher the IP and the worse the condition, the more it will respond to replacing this thickened lens with a smaller, thinner artificial IOL. The extent of PAS is also controversial. Some have found that the more the extent, the better the results of phaco, probably because of the reason we just mentioned, that phaco would lyse some of the synechia, and some found that it's unrelated and irrelevant, the extent of PAS. Now, there's more of an agreement on anterior chamber depth. It looks like there's an inversely proportionate relationship. The shallower the anterior chamber, the more effective the phacoemulsification, which makes sense because if the anterior chamber is very shallow, then the lens is definitely a strong contributor. And interestingly, females have been found to respond more to phaco alone than males do. So, if we don't know still which patients would respond to phaco alone, is it justifiable to do phaco trabs for all patients just in case? Well, the answer is no, because adding a bleb to a phaco needs to be really justified because of all the bleb-related risks that we run into over time. So to decide to do a phacotrabeculectomy, you really need to have a solid reason for that. So let's look again at the evidence. Two sister studies, the important sister studies by Pham and co-workers from Hong Kong, they compared phacoemulsification alone to phacotrabeculectomy, first in medically uncontrolled glaucoma, and their sister study was in medically controlled glaucoma. So this was a 2-year study, and in the first study with medically uncontrolled glaucoma, out of the 27 eyes that were randomized to receive phacoemulsification alone, only 4 eyes required a trabeculectomy by the end of the study over the 2 years, which means that 23 eyes were salvaged from doing an unnecessary trabeculectomy in addition to the phacoemulsification. In the second study with the medically controlled glaucoma, there were 35 eyes that had phaco, only 1 required a subsequent trabeculectomy. So it was a proper, good decision to perform phacoemulsification for those. The authors reported, of course, a lower IP in the phacotrab group and a significantly less number of medications, but that was at the expense of a high risk of complications, mostly hypotony related. So based on these, we ran a study, on these results, we ran a study in Cairo University where we thought of comparing phaco to phacotrab, but in this case, we did phacotrab using a different technique. So we used releasable sutures to completely occlude the trabeculectomy so that we do not depend on it in the early post-operative period. We would depend solely on phacoemulsification. So instead of taking the usual 2 or 3 releasables like we do, we took 4 or 5 releasable sutures aiming at no flow through the trabeculectomy, no bleb, as if we haven't done any trabeculectomy, but we had the key to those releasable sutures post-operatively. So once the pressure is not sufficiently reduced, post-operatively, we started removing those releasables, so we would kickstart this bleb or trabeculectomy to start its function when we need it. And if we didn't, if the pressure was fine, we just did with the phacoemulsification results. And interestingly, the results were very similar between doing phaco or doing phacotrab with all these manipulations. So again, phaco or phacotrab is controversial in primary angle closure glaucoma. My own nomogram for now is to do phacotrab in 2 situations only. So the subset of patients where I would consider doing a phacotrab for are patients, first of all, with advanced glaucoma, especially if I don't want to expose them to the risks of local anesthesia because of health problems or because of the very advanced glaucomatous optic neuropathy that may not tolerate local anesthesia several times, particularly for patients who are less compliant with follow-up, especially if these patients undergo a successful phacoemulsification and find that the vision has improved remarkably. You may not see them again with their advanced glaucomatopathy, and they may return later with a loss of vision because they didn't come back after the phaco. And finally, in advanced glaucoma, where patients can't tolerate medications or can't comply or afford medications, you're more likely to be off medications with a phacotrab. So for these patients, I would be more inclined to do phacotrabeculectomy. The second scenario is when I suspect non-pupillary block mechanism. Like someone was asking earlier, what would you do for a plateau iris? So if I suspect plateau iris, I would probably be a bit more inclined to do phacotrab. There are other mechanisms, as I said, that we have less information about, like the thick iris volume, choroidal expansion. So for all these, I suspect them once I feel that the lens volt is not high. So if the lens volt isn't high and the central anterior chamber is quite deep, so I would suspect that pupillary block isn't the main culprit here. So these cases are less likely to respond to lens removal alone. So as you can see in all these OCTs, the angle, the width of the angle is very similar. They all have narrow angles. But this first case is narrow because of pupillary block, a high lens volt, and a shallow anterior chamber. Whereas in this case, the anterior chamber is centrally deep, the lens volt isn't high, but the iris volume itself is thick and it's contributing to the narrowing. So this patient, I wouldn't expect them to respond as well to phacoemulsification. Similarly, in this patient with not a very high lens hole, a slightly deep anterior chamber, but a narrow angle because of high iris curvature. So these cases are less well understood, but if you spot them, if you suspect them, then you can consider doing a phacotrabeculectomy. Now, finally, what is the role of clear lens extraction in angle closure? As I said earlier, whenever you decide that this patient, an angle closure glaucoma patient, is for surgery, then lens extraction is the solution, whether this lens is cataractous or whether it's clear, because and patients need explanation in this sense. When you tell them we're doing cataract surgery, maya bida, but I have glaucoma, maya zarqa, are you confused, doctor? So you have to explain to them that this is not the lens is the main reason, whether it has a cataract or whether it's clear. In addition to that, clear lens extraction in patients that are hyperopes is very visually rewarding, so it's an added plus to do it when indicated. So I'll just mention the eagle eye study, which is the most solid evidence in this aspect, where the eagle eye study, this is a major study that was published in Lancet a few years ago, that compared PI, peripheral iridotomy, to clear lens extraction in patients with primary angle closure and primary angle closure glaucoma. And it's very important when you hear about these studies is to look back, especially these influential studies, is to go back and look at their inclusion criteria, look at their limitations. You need to critically analyze these studies rather than just extrapolate what you read in the results to your patients, because these inclusion criteria may not be applied to your patient. For instance, they included primary angle closure with a pressure of 30 millimeter mercury or more. So if a patient has a 25 millimeter mercury pressure, the same rules may not apply. They included patients 50 years old, 50 years or older, and they included primary angle closure glaucoma patients with a pressure of more than 21 millimeter mercury. They excluded patients with advanced glaucoma. So again, you may not be able to extrapolate the same results to advanced glaucoma patients, patients with previous acute attacks, or patients with previous PIs or lasers in general. And they compared the two groups. Of course, the two groups were randomized to PI or clear lens extraction. They compared them in terms of quality of life questionnaires, visual acuity, IOP, medications, visual field, and complications. And again, to cut a long story short, out of the 419 eyes randomized, 208 had clear lens extraction, 211 had laser PI, and the clear lens extraction group was superior in all aspects. They had a better quality of life, more IOP reduction, less likely to have another operation, and less likely to have complications. But then again, you need to individualize treatment. We take these in the background of the way we think this evidence, but then not all studies can apply to all your patients. You always need to individualize your treatment. So to sum up, there are angle closure is full of controversies, which makes it more and more interesting. I really like this subset of glaucomas, and as more and more evidence is coming up, we do change our practice sometimes. So the first controversial point is the need of PI in primary angle closure suspects. You're justified to do a PI in some cases, and you're justified to leave them alone. Both are correct. And again, you need to individualize, look at your patient, and consider it case per case. The second controversy is doing PI or phaco in primary angle closure and primary angle closure glaucoma. Most of us will go for phaco, but there's still a big role for PI as a minimally invasive laser procedure that can salvage a lot of eyes from even a minimally invasive intervention like phaco. And finally, whether to do phaco or phaco trab in primary angle closure glaucoma, and still, as more evidence appears, we keep on changing our decisions in these aspects. Thank
you. Do we have some room for one or two questions? Turasmin, there's a question from the audience. Turasmin, can you hear me okay?
Yes, I can hear it.
Okay. There's a question from the audience about adding trabeculotomy after phacoemulsification in cases of peripheral anterior synechial angle closure.
Trabeculotomy.
Yes, trabeculotomy. This question
I'm,
can
a,
be
I'm an avid believer in, yes,
trabeculotomy.
absolutely, absolutely.
So
I do believe that angle surgery has a big role that needs to be looked at in angle closure as an adjunct, of course, to phacoemulsification, so it can be done alone. But yes, definitely. It can reverse the trabecular damage that has happened because of the constant friction, and it can lyse some of the synechia.
Sure. Now, mentioning synechia, you've mentioned, of course, that just the inflow of the fluid and the bottle height and the fluidics of phaco itself, they break the synechia. If you're going to do goniosynechiolysis, would you strongly recommend an intraoperative gonio lens, or it can be done simply by just injecting viscoelastic blindly in the angle? What's your opinion about that,
Well, I personally do it without the gonio lens, but then because of this, it makes it easier and quicker. And the reason mainly, again, I go back to the evidence. The evidence is very controversial regarding the usefulness of doing viscogoniosynechialysis to start with. So there are randomized controlled studies that strongly support it, and others that strongly find that it doesn't add any benefit. So I do it as an extra quick step. And I wouldn't spend too much time on it, not being sure how useful it is.
Okay. Now, one final issue that I would like your comment about, generally speaking, and Professor Abdurrahman, please would join us. The big issue with the extreme form of angle closure, which is simply nanophthalmia. We happen to have a subset of these patients in Alexandria. Definitely, you definitely have seen lots of these cases. So, what about the extreme, which is nanophthalmia? What about PIs, phacos, medical treatment? Any word that you can tell us about nanophthalmia, because this is a really, really big problem?
It's a very difficult issue, Nader, you know that. And actually, I'll just answer from the cases which I have done. For the nanophthalmics, if they are having no pressure elevation, because sometimes you're having nanophthalmic eyes, and they are quite high hyperop, like plus 18, plus 20, and the pressure is normal. I personally don't like to play with those eyes at all, because I just remember when I did PI to one patient, it excites glaucoma. So this is number one. The second issue, if they are going to develop glaucoma, you know, a lot of controversies there, and definitely most of the most of the surgeons would think of removal of the lens, as it will give some room, and then you can combine with a kind of anterior vitrectomy, and then you can think of the power of the lens. How are you going to correct that those cases with, like with and then you know that piggyback it's not always an easy option in a glaucoma. It's very small eye, so that you keep thinking about the other options as well. And then there is a room for some other procedures, like the vortex vein decompression. Some are talking about that, and I think there is a good role also for the cycloablation procedure in those patients, because I think the cycloablation induces a retraction of the ciliary processes, which could help in deepening of the anterior chamber in one way or another. There is no universal agreement in the literature
Sir,
about
the classic diode, not the micropulse in this situation, right? Or
the classic diode, yes. Yes, and I have a handful of patients with that. I treat and then I retreat, and I will feel happy if they are controlled, even with the possible medications that they can tolerate, and I avoid the opening of those eyes.
Okay. Now, finally, sir, how frequently do you find yourself needing to do a TRAB after a successful lensectomy in a patient with angle closure and relief of the corneal edema? Angle closure attack, controlled lensectomy, controlled, and the corneal edema resolved, but the pressure is still high, necessitating a TRAB. Let's say, would this scenario be common in your practice, or after lens extraction, it usually RP normalizes? What's your experience? That's the question from the audience.
Yes. Yes, for me, you know that we do our best to terminate the acute attack, and I have tried in patients who are having pressure that's persistently elevated despite all the medications, including systemic therapy, to do them paracentesis and intracameral myotics, and they responded dramatically to that. And definitely, I would go for phaco after normalization of the pressure in those eyes. And I just keep thinking for the studies coming that the pressure dropped from 50 to 20, because it's not easy to have a patient with 50 to the OR and do phaco. It is, even if the lens is clear, it's a big risk. So that I do all my best, including doing corneal indentation with a 4-mirror lens, doing paracentesis, injection of, I know this is not written in the literature, but I have done that on a few patients and it worked well, so that I do my best to control the pressure, and then I leave the patient for a few days just to have, and definitely
after the cataract, sir, if the pressure is still elevated, then you would do a trabecular eye with previously narrow angle. There's no problem with that.
Yeah, but I'm understanding that the question, the patient is having glaucoma and the pressure is quite high, and then you will do phaco surgery. That's the scenario, or you are talking about? That's the scenario. Yes.
After doing the phaco, the pressure is still elevated. The phaco was successful. No problems happened with the phaco. The
you know that I like the comment of Yasmin that those angles are suffering and the trabecular meshwork is suffering, so that you need to give time. It is not you just you push more steroids, you give anti-glaucoma medications, avoiding definitely prostaglandins. You give alpha agonists. I give systemic carbonic anhydrase. I just wait, and then you can expect good surprises and good response. It is not just, you know, that
so
it is
you
not.
mean you give time for the tissues to recover from the previous insult, sir? You don't rush immediately to attack. Yes, thank you very much, sir.
You know, don't wipe a tired horse. It is not just like that.
Tired horse. Exactly, sir. Yes. Thank you very much. That is a great comment.
I have one point. I'm not sure if the question was referring to angle closure or acute attack or chronic elevation, primary angle closure glaucoma. But if the question was on primary angle closure glaucoma, how many cases require a trab after phaco? Then in our study that we run on Egyptian eyes, out of the 33 that had phaco for primary angle closure glaucoma, 2 required trabeculectomy within the 1-year study period. One, I looked up the study, one was at 4 months and the other at 9 months. So as Dr. Ahmed was mentioning, it's not in the early post-operative. We give it some chance to make sure that it's not a steroid response, but you can expect, at least in our population, that 2 out of 33 phacoemulsification cases required a subsequent trabeculectomy within 1 year.
So, these 33 cases were, did they have any parameters regards how many medications were they are on? What is the level of IOP rise, IOP control or not control?
They were all, no, we included both controlled and uncontrolled cases, but the controlled cases were mostly patients with cataracts. There were a few cases with clear lens that were uncontrolled on medications. So it was more of a miscellaneous inclusion criteria. So it included both clear and cataractous lenses, but the indications, of course, were different. So we had a lower threshold to intervene if they were uncontrolled.
And they were uncontrolled despite of maximum medications.
Of medications that they can, and there were patients that were controlled, but that had a significant cataract. So we went ahead and did the cataract. And so eventually, with all these cases, out of the 33, 2 required a trab.
That's interesting. I would just try to go through some clinical cases which I met. And this is our situation of a patient with completely occluded angle. Now, I have seen patients who sustained an acute attack, and as you said, Nader, and they are refusing to have their pressure controlled, and they can come and say that my pressure is elevated for a couple of months persistently, and the attack is not controlled. And this is unresolved acute attack of angle closure glaucoma. Like this patient, she was a 40-year-old lady with an acute attack a couple of weeks, and then the pressure was 45 on full treatment, and then the biometry as expected was 26. And again, here, And then you can think what could be done. Again, the pressure is not controlled despite of maximum therapy. And usually those patients are having pupils that are permanently dilated as a kind of Zavalia syndrome due to the effect of ischemia by the pressure for that long time. And definitely removal of the lens is not a big problem, but we need to keep the eye pressurized all the time, and then so that we should avoid hypotony for fear of malignant glaucoma. And then I'm here putting the gonio lens and trying to get that iris, because in 2 weeks still the iris, possible to get the iris from the angle. In the old days, I used to use the forceps, and I have changed this practice nowadays. Again, I'm trying to get as much as possible iris from the angle, and you can see the peripheral iris is atrophic because of the effect of ischemia. And then we need to repair this iris, because this iris will remain permanently dilated as a value effect. And then again, this is the simple single pass pour through suture, which is so helpful in restoring the pupil. And then now parts of the angle are seen, and the beauty about repairing the pupil is that it will try to avoid reformation of the peripheral anterior synechia that could happen. And then this is the picture in the immediate post-operative with a good response of this eye. Now this is another case which had a similar scenario with the pressure even higher for 2 to 3 weeks, and then the biometry is 25, and then we can keep thinking of what to be done. Again, the glaucoma surgeons with angle closure glaucoma are switched to be cataract surgeons, but in a bit difficult situation. So this is the situation here, where the pressure was again high and the eye looks tense. Definitely you can help yourself with a kind of vitreous aspiration or systemic therapy. But again, this is intraoperative gonioscopy, where you see the angle is completely occluded, and then nothing in all quadrants, and this is a 4-mirror lens. Intraoperative, nothing. This is a completely, it looks like synechial closure. That's an attack that persisted for 3 weeks. So that's just the evaluation of the angle. Now we will start the surgery. Definitely we go very slowly for giving a chance for decompression, and then filling the eye with 1 or 2 types of viscoelastic. Again, trying, you can see that the anterior chamber is shallow. That's as expected, and the lens is a bit bulging, and that's normal in those patients, and we need to get used to that. And then doing the rhexis, definitely we try to avoid the lens, the rhexis extended, and then the lens removal itself is not difficult. And then here I put the IOL in the bag, and then I inject myocol and I inject visco into the angle, as Yasmin is doing. And then I have tried to get the iris from the angle, because this is just 3 weeks after the attack. And I'm quite sure now that this iris, if I'm going to leave this eye in this situation, post-operatively, the pupil will remain dilated. There is no reason for this pupil to constrict after the pressure elevation for a few weeks. It's usually ischemic and atrophic. So I need to repair that pupil. And I think that's a step for management of glaucoma as well, not only the pupil and the aberrations, but it will help in that angle, that good part of this angle has opened, we really don't know, but that will keep that angle from reforming peripheral anterior synechia, because it is known that those synechia can reform. And that's the picture in the post-operative, again, relatively quiet eye. Now, this is a different story, a patient which I have seen this patient very recent, and then the patient is having that picture, chronic angle closure glaucoma, and the pressure is quite high. And you can see that the lens is a big lens, and there is no almost posterior chamber. And then when it comes to the operation, then you can see the iris is ischemic from the long-standing elevation of the pressure. And then I will go for phacoemulsification, because that was my always plan. You can see here that the incision is going into the lens. The lens is bulging forward. There is no space in the anterior chamber. And then I just get my instrument, my knife out, and then I'm injecting more of a helon into the whole anterior chamber. And then I realized that the lens is subluxated as well. And this is part of the pathology of chronic angle closure glaucoma. You can find the lens is in an anterior location and even some kind of subluxation, so that I need to take this into my consideration, that this lens, I have to be extra cautious during dealing with this lens, so that I started my Rexus, and again I refill with the Helon, and then I come back to the lens, and I try to continue my capsular Rexus in a complete fashion, so that it will take a bit of time. And it was not easy to identify the subluxation of the lens preoperatively. The pupil is dilated, and then there is no way to confirm that, and even with the UBM, it was not conclusive regarding this point. And then the Rexus actually has been completed now, and you know that there are different techniques for dealing with the lens that is showing that kind of mild subluxation. And then one of those lines definitely is to put a capsular tension ring, which seems like the easiest option in those eyes. So that I wanted to support my lens more by insertion of a capsular tension ring, so that you need to be prepared. And I think the message here, when dealing with an eyes with the angle closure glaucoma, you can meet something that is not expected, and one of those is the subluxated lens. So we are having a capsular tension ring. That lens was put in an injector. You need to place it manually, and it is being placed. There is no problem with that. And this is the last piece of the capsular tension ring. And now I feel more satisfied about the position of the capsule. Now cataract has been accomplished normally with the polishing of the capsule, and then I'm enlarging my capsular Rexus after implantation of the intraocular lens. Again, I'm going towards the angle. I like to take my spatula nowadays and to press on the peripheral part of the iris in the all quadrant, so that if it is possible to get to push the posterior synechial to the back. And then manually I'm trying to retract, and you can see the iris is ischemic from the long-standing elevation of the pressure. We don't see this feature in open angle glaucoma, whatever the elevation of the pressure is. And then I will go for repair of the iris, because I'm quite sure that repairing the pupil is part of the glaucoma management. And we do like the single, it is just single pass through technique, which I think is quite easy. It needs a kind of training which is not very difficult, because it is just a single suture. And then you need to think, do you have to repair the rest of the iris or not? I was just confident that this will bring the iris to a good level. That's the patient in the post-operative, and expect more response from the eyes that they are having high preoperative intraocular pressure, because decompression of those eyes can result in more inflammatory response, and also dealing with the iris can result in more inflammatory response. Now, the issue of phaco trap has been nicely touched. I was completely against the phaco trap for angle closure glaucoma, and actually that was an old video for two-side phaco trap, because I was not confident about the results. But nowadays you can think that one of the recent surgeries. Now, if you meet a one-eyed patient, the disc that's 9 or even 1, and then is having pressure that is terrible and not controlled, yes, you will do phaco. You can see the lens is clear phaco, but what about the glaucoma? And then what I'm doing nowadays for a very narrow subset of a small subset of patients, I do trap, and then I use the releasable sutures in the way that Dr. Yasmin have said, so that it is now in one of my management options, but it is not the priority. It is just for very, very, very few subset of patients. It is based on the observation that patients undergoing phaco alone, yes, they are having dramatic improvement in the pressure, but they still can need few medications. So that I'm thinking that could it be better if we just do a trap and then we close it tightly? And I'm doing it through the same incision as Yasmin is doing exactly. I complete the phaco through the incision that I'm going to do a trap. And then usually those lenses are not hard lenses, completing everything, putting the lens, and then I will put one releasable suture at the apex. After I put the lens, I tend to inject myotics. So just my PI would be an easy job. And then I use the punch to do just a tunnel so that it is not a huge trap, it is just a tunnel. And I stop almost at the scleral spur. And then after doing the iridectomy, and then I will prepare the releasable suture at the apex here. And then I'm putting 2 sutures so that I close everything tightly. I don't want to have filtration except on very, very high pressure. And then yes, and those patients might need some needling in the post-operative if we need, because they scar more rapidly. Yes. So that's a picture showing patients who underwent combined surgery, and then almost the trap site has a scarred, so that they benefited from the phaco. So what I want to avoid in those patients, I want to avoid doing trabeculectomy alone, as Yasmin has nicely mentioned. I want to avoid excessive filtration if I'm going to do a combined surgery on a very, very small number of patients, but I want to avoid excessive filtration, and I need to avoid hypotony, whether intraoperative or postoperative, because it is a strong precursor for a lot of complications, including the malignant glaucoma. Now, if you are going to do a trab, you can expect galloping of cataract like this patient. This is the most frequent situation, and this is not a piece of cake cataract, of course. Now, to avoid overfiltration, this patient was referred to our center, and a one-eyed patient, male patient, underwent combined phaco trap. And the problem with that patient was he was hypotenuse because of overfiltration. So what happened here, that a lot of antimetabolites were applied, a lot of filtration, and then you can see the whole iris is adherent to the periphery. Then I have to repair the whole surgical site again. I found no reasonable option except scleral patch. And then I want to serve the whole iris from the back of the cornea, so that we need to avoid hypotony in the early postoperative, because we can get those pictures where the iris will start to be adherent to the back of the cornea and will end up in having a decompensated cornea, even if the pressure remains controlled. So that I'm separating the iris from one side, then I will switch to the opposite side and separate the rest of the iris. Again, we don't like to deal with those situations. They are avoidable actually by avoiding hypotony in the early postoperative period, and the patient is now having nicely controlled the pressure, nicely formed chamber with scleral graft underneath. That was the picture preoperative. Definitely, what led to that picture, again, it is just the hypotony. So what I do in patients with chronic angle closure glaucoma, just phaco, definitely, phaco GSL, goniosynculitis, and then if phaco goniosynculitis was not effective, I can do trap, but believe me, like a couple of years now, I'm doing that phaco GSL, and none of the patients require trabeculectomy. And also after phaco, probably with extended follow-up, some of them might need, but again, it is still an option that you can go next for trap or some other options, or you can have phaco trap on a very, very small subset of patients. But about peripheral iridectomy with laser, and that patient had actually a primary angle closure, so that he's having elevation of the pressure, and then we agreed upon doing just PI. And what happened that after PI, that patient disappeared for like 4 years, and then he came back with pressure of 30 in one eye and 28 in the second eye. And upon doing investigations of this patient, I realized that the patient has progressed, so that I just didn't feel okay that the patient disappeared for like 4 years with the PI, then he came back with that with progression. So we need to think, as Yasmin mentioned, that the effectiveness of lens extraction for patients presenting with pressure above 30, because they are better management with cataract surgery. Now, with the last group of patients, those who presented with an acute attack after PI, again, this patient presented with, she's having a nice PI, and then she came back with an acute attack of glaucoma. Definitely we think of plateau iris, and that's the clinical clue in those situations. And I have sent the patient for UBM, and it concluded the diagnosis that the peripheral iris is elevated by the ciliary body. And then we need to think that, are we going to do for those patients cataract surgery? Are we going to do iridoplasty? I think it's a bit controversial issue, but cataract surgery is not the optimum management option for those patients, because they still can have the ciliary body elevating the periphery of the iris. You can combine the cataract with a kind of cycloablation to retract the ciliary processes, or there's some evidence that supports the iridoplasty. So again, what's happening nowadays is that we are replacing our trap with cataract surgery, even on clear lenses, as Yasmin have said. The lens is the cause of the glaucoma, and the patient has to know that. And in most of my patients, after I implant the lens, and then I like to put my gonioprism, and then I investigate the areas of peripheral anterior synechiae, and then I lyse them with the spatula. And then another option which I do, that at the conclusion of the surgery, I kept injecting air so many times, because I'm quite sure that when you push the iris lens diaphragm by the force of air, that can help in lysing some of the synechiae. So that's the situation nowadays, and the angle can open after phaco and GSL. Yes, phaco difficulties, Nader, you have touched upon that. You know that the short eyes could be hyperopic, microphthalmic, or the difficult nanophthalmic eyes. So that again, yes, cataract surgery and the lens is clear, but it's not a piece of cake, because some difficulties related to the cornea, even that sometimes when the cornea is small, you feel the incision is taking like 1/4 of the cornea, and they are having difficulties with the key readings of the cornea, shallow anterior chamber, pupil which do not dilate, iris prolapse. That's why you should have nice construction of the incision, IOL calculation, refractive surprises, glaucoma control. So a lot of concerns around the cataract surgery in those patients. And sometimes you need some hooks, as Yasmin have shown, to help in dilating the pupil. And look at this patient. I'm trying to do Rex. The pupil is not dilated. Definitely what I'm doing here shouldn't be done. I should have the pupil nicely dilated. But look, when you just try and then the iris will come, it's very bad to do that. Just try to dilate the pupil as much as you can, put iris hooks, and feel relaxed while doing the surgery. And I keep injecting air. And so that pre-operatively, we like to have proper counseling of the patient for the glaucoma and the refractive outcome, especially for eyes like the nanophthalmic eyes. There are some recommendations for imaging of the eye. Operatively, make sure that the speculum is not exerting too much pressure on those eyes which are already small. You can use a combination of dispersive and cohesive viscoelastics. We can dilate the pupil using iris rings or hooks. We may need some limited anterior vitrectomy. It's very important to avoid hypotony during the operation, so that you tend to keep the anterior chamber pressurized all the time. Post-operatively, definitely keep an eye on the pressure. Yes. And take care of yourself in the era of COVID. And thank you so much.
Thank you very much, Dr. Ahmed, Dr. Yasmin, for this excellent presentation.
Thank you,
excellent
Ned. Thank you, Ned.
Now, Professor Ahmed Khalil has an announcement to make about the assessment.
Okay, so thank you for this rich session, for the excellent also coordination and questions raised by Dr. Nader. Thank you for our very dear speakers. And regards the CME, an email was sent for anybody who attended at least 2 sessions of the previous, and to attain the minimum CME, you need to attend at least 5 sessions. So if only attended 2, you'll probably get already your email, and you can go the examination, which is online now, till tomorrow 10 a.m. But you need to attend further sessions in the coming episodes. This is one, and this episode 7 actually. After this, we will have a short break because we are preparing for our annual meeting, which will be held on Friday, 13th of October. So we are 2 weeks, exactly 2 weeks from now. So we would like to welcome you all to our annual meeting. We promise you a very rich conference, physical conference, obeying all very necessary social distancing. Each seat will be at least 1.5 meters from the next seat, and we will enforce very vigorous and firm regulations for the benefit and for the health of everybody. We need to do our physical meeting, and to also has a virtual part. We have 6 international speakers on the highest standards from the east to west, starting from Japan, India, Europe, and Canada. So we have actually a very rich content prepared by our scientific coordinator, Dr. Yasmin. So we wait you to see you then. The next episode, episode 8, will be on Friday, the 5th of November, and it will be on medical and laser treatment of glaucoma. So looking forward to see you then all, inshallah, safe. Thank you for being with us that late, and see you, God willing, on Friday 13th in the annual meeting of the Egyptian Society for the Glaucomas. Thank you very much.
Thank you. Thank you. See you. Bye-bye.
See you. Now we conclude with our sponsor, Orchidia, promotional ad, please.
Hello, doctor. Greetings from Orchidia Pharmaceutical Company. I hope you, your family, and all your beloved ones are safe and in good health. Today I'm going to talk about our latest introductions for your glaucoma patients. Taflopro single dose unit offers better IOP control to reach a target IOP. Taflopro single dose unit reduces IOP significantly in patients with prior prostaglandin monotherapy. Taflopro single dose unit ensures no severe hyperemia experience with other prostaglandins. Another product for your glaucoma patients is Taflopro plus single dose unit. Taflopro plus single dose unit provides numerous benefits when compared to non-fixed combinations. Taflopro plus single dose unit offers extra IOP control up to 22.3% when switching from prostaglandins analogs. Taflopro plus single dose units offer a better local comfort. Thank you for your time.
So thank you all, and see you in 2 weeks' time in the our annual meeting, and then on the 8th episode on the 5th of November. Thank you and goodbye for all.
Thank you so much. Bye.